you, Kirsten. Thank you very much for the great lecture. And it's now time to go to the next speaker, who is Isabel de Mister. And she will discuss ovarian tissue versus oocyte cryopreservation in this subpopulation of adolescent girls. So, Isabel, we're listening to you.
Thank you very much, and thank you for the invitation to and to give me the opportunity to discuss with you this challenging topic on ovarian tissue cryopreservation versus oocyte vitrification in adolescent girls. So, yeah, I have no conflict of interest regarding this presentation. So to start the presentation, I would like just to go back to the guideline, actually, as we have a guideline available since soon about fertility preservation in childhood, adolescent, and young adults, published by the PanCare Life Consortium, which is a large consortium of international experts. And the guideline was based on 45 selected studies. And if you just go quickly in the table where they actually recommended the procedure for fertility preservation in post-pubertal adolescent and young adults with, of course, who receive, of course, who have a high risk of premature ovarian failure. Actually, oocyte and embryo cryopreservation are strong recommended, and ovarian tissue cryopreservation are moderately recommended. So while we have to further discuss about this situation in adolescents, but it's because the strong recommendation regarding oocyte and embryo cryopreservation in the guideline were based mainly on the evidence available in young adults, because the criteria for the selection of the study was a patient less than 25 years old in the guideline. And the panel acknowledged that it's not appropriated for prepubertal and peripubertal girls, but there is no age cutoff about the procedure. And second point is that out of the medical and organizational limitation we will discuss in this presentation, the panel acknowledged the ethical complexity and requirements of physical and emotional maturity in this population, and we will discuss that, I think, in the next talk. They also based their recommendation on the fact that there is few evidence for ovarian tissue cryopreservation efficiency in this young population. And so what are really the evidence and the specific issue for adolescent girl? If you have to choose between two procedures, you have to balance the risk and the benefit of each of them. The benefits is certainly the success rate in terms of live birth, but also the benefit in terms of quality of life. The risk will be the complication, the risk of recurrence of the disease, the invasiveness of the procedure, and the risk of additional increasing risk of premature ovarian failure, for example. So what about ovarian oocyte vitrification? You certainly know the advantage and the disadvantage of this procedure. You don't need any surgery. It's well known efficiency is well known in adults, but you need an ovarian stimulation that takes 2 or 3 weeks. You can only collect a limited number of oocytes per cycle, and it's not feasible in children and after initiation of chemotherapy. So what we know about oocyte vitrification in adolescents, but actually there is very limited experience in oocyte vitrification in adolescents. Here you have a large US study where they reported more than 300 cycles for fertility preservation in young patients less than 20 years old, and compare them with other group of age. And here I just reported the group of 20-29 years old to compare. There is no difference in terms of number of oocytes collected and number of oocytes cryopreserved. But as you can see, more than 35% of these patients have less than 11 oocytes cryopreserved after control of iron stimulation cycle. It's important to notice that more than half of them have actually 18 and 19 years old, so it's considered as old adolescents. And the mean number of cycles they could perform in these patients for fertility preservation was 1.3. So most of them have only one cycle of oocyte cryopreservation before gonadotoxic treatment. Complication rate was 0.6. There is no increased risk of the procedure in adolescent and young population. But if you compare with the 20-29 years old group, there is a higher cancellation rate, double cancellation rate, 10% versus 5%, but similar maturation rate, and also a trend to need a higher total dose of gonadotrophin for this young population. And this was confirmed by other groups who report a trend to have a higher dose of total gonadotrophin, even if not significant in this small population, for a similar number of mature oocytes collected. So what does that mean, and what are the age limit for the procedure? Actually, there is no age limit for the procedure that have been described, and there is even case report of the procedure in premenarchal female with, here it's a girl with myelodysplastic syndrome. And they collected 20 oocytes, but only 8 of them were actually mature. So altogether, this data suggests that it could be less efficient actually to do oocyte cryopreservation in adolescents than in young adults. So, but the most important is actually the outcome and the success rate of the procedure in terms of live birth. The data we have is in adults, and you all know this evaluation of the cumulative probability of live birth in infertility patients. And from the group of Kobo, published in 2018, and for patients who have less than 35 years old and have 10 oocytes cryopreserved, the chance to have one live birth is around 40%. We have no data really on the live birth rate obtained after thawing and fertilized oocyte cryopreserved during adolescence, and there is only few case reports. But maybe one of the way to address this issue is it worse or better to have oocyte cryopreserved in adolescents than in young adults, is to look at the quality of the eggs. And for that, we have an excellent paper from the group of Copenhagen where they actually analyzed the chromosome errors in human eggs over reproductive lifespan. And what they observe is that, of course, the proportion of aneuploidy in the metaphase 2 oocyte is actually lowest in the group of patients who have 20 to 30 years old, who are 20 to 30 years old. And as expected, is increasing with age. But they also observe that the aneuploidy rate is high in young population less than 20. And this was also reflected by the fertility rate, which is optimal between 20 and 30 years old, but decrease in the younger age and in the older patients. And when they analyzed the embryo obtained from the different fertilized oocytes at different age, they observed a higher proportion of maternal trisomy in the young population less than 20 years old. So all these analyses suggest that the quality of the oocyte is probably not optimal in adolescents compared to young adults. But if you want to overcome this issue, you can maybe increase the number of oocytes you vitrify to increase the chance to get a pregnancy. And this is maybe possible in non-oncological indication, as discussed in the previous talk. And here there is a case series of 8 patients who perform oocyte cryopreservation during adolescence for sickle cell anemia. But you can see here that 50% of them have less than 10 oocytes collected after one cycle of ovarian stimulation. That means that these patients have to be prepared to have more than one cycle, more than 2 cycles, even 3 or 4 cycles, to have a reasonable number of oocytes vitrified. That could be quite invasive for adolescents. What about ovarian tissue cryopreservation? Again, you know the advantage and the disadvantage of the procedure. This is a rapid procedure, and an important point is that it can be done on site, because we talk about patients treated in pediatric hospital. They don't have fertility center usually just on site. But the laparoscopy can be done on site. You don't need any ovarian stimulation. You can cryopreserve a high number of follicles, possibility to do ex vivo IVM also. It's a procedure available whatever the age, and in children, I mean. And importantly, you can restore fertility after graft, but also ovarian function. Of course, it's invasive. You need the laparoscopy. There is the risk of disease transmission after graft, and it's considered as still experimental in children. So you know the procedure. The ovarian biopsy or oophorectomy can be done on site. The tissue is transported at 4 degrees up to 24 hours until arrived at the lab, where the cortex is processing for freezing procedure, and immature oocyte can be collected when feasible for long-term storage. Altogether, this is a procedure that is safe, with a complication rate around 0 to 4% according to the study. If we look at the literature regarding the procedure performed in children, you can see that many centers actually propose this procedure in children, but also in adolescents. And there is hundreds of adolescents now worldwide who have performed this procedure for oncological and non-oncological indication. In our department, the patient less than 18 years old represent 26% of our population, but you can see here that the adolescent classified as patients between 15 and 17 years old represent 5% of the population, and the indication actually well correspond to what has been described in the previous talk. So what about the success rate for transplant, use the tissue for fertility restoration? You need to transplant the tissue, and that can be done in one-step laparoscopy, robotic laparoscopy, or standard laparoscopy, and usually at orthotopic site to increase the chance of pregnancy. So out of the 20 patients we perform who have at least 1 year of follow-up, actually in our department, 45% get at least 1 pregnancy and 1 live birth. 8 have at least 1 baby, and 1 is ongoing now. So the success rate is well known in adults now, and you can see here the range of age at ovarian tissue cryopreservation was between 13 and 35%. For the patients who have 13 years old, actually the cryopreservation was performed before bone marrow transplantation for sickle cell anemia. She actually was premenarchal, so after treatment she need to have hormonal substitution to get menstruation, and she came back at the age of 24 years old for fertility restoration. We transplanted 15 fragments out of the 62. And as expected, she restored normal ovarian function after 5 months. And actually, she has a spontaneous pregnancy and live birth after 2.5 years after graft. And the delay is due to the fact that she has a new partner. And she has a second pregnancy and a live birth 6 years after graft, so a second baby. And after delivery of the second baby, she still recovered menstruation. So that means that for these young adolescents who have ovarian tissue cryopreservation, she has 2 babies spontaneously after transplantation. We have still tissue in the bank, and she benefits from 7 years of normal ovarian function with normal menstruation. What about the literature? There is a recent meta-analysis of more than 500 women who has been transplanted, and they report a pregnancy rate of 37% and live birth rate of 28%, with an advantage, a benefit of being young at the time of cryopreservation. But in this analysis, they don't focus on specifically on young population. Actually, we have done that in a review in 2019, where we analyzed the data from 18 patients who have less than 21 years old at the time of cryopreservation and who have underwent ovarian tissue transplantation. And from this group of patients, 16 tried to get pregnant, and 9 of them have at least 1 live birth, meaning that 56% have at least 1 live birth. So it seems that the success rate of the procedure in young population is better than in general adults. In this cohort, there is only 5 patients less than 15 years old. Only 3 have done the procedure for fertility restoration, 2 try to get pregnant, and 3 live births have been obtained in these 2 patients. So we know that there is several issues regarding cryopreservation of ovarian tissue in children, but actually the question is mainly regarding the use of ovarian tissue cryopreserved during prepubertal patients, based on animal study showing that oocytes from prepubertal animals actually have a lower developmental competence, and also by the fact that we observe a lot of abnormal follicles in very young patients. And we know that there is a huge decrease in the follicular pool during prepubertal stage, with probably a selection of the follicles. But this is less the case during adolescence. So what is offered in practical, although we acknowledge that there are more data on the outcome using vitrified oocyte and cryopreserved tissue in adults, ovarian tissue cryopreservation remained the first option offered in many centers, including in our center for adolescent girls. Why? Because of the choice of the patients, the possibility to combine anesthesia, as we discussed just now, the issue of the delay, the organizational issue, the facility to do the laparoscopy on site, the benefit in terms of quality of life, restoration of the ovarian function, possibility to get spontaneous pregnancy after graft, and I think the higher chance to have 1 or more than 1 live birth if you cryopreserve the tissue. But this needs to be confirmed. So in conclusion, I would say that oocyte vitrification is recommended as the first option in young adults often, but it's not often not the first option for adolescent girls. The age cutoff for an optimal efficiency and success of the procedure need to be clarified. It is probably appropriated for specific indication, such as transgender, future patients who need future genetic screening, risk of neoplastic cells within the ovary when there is a high risk of neoplastic cells within the ovary, some benign ovarian disease with moderate risk, endometriosis, recurrent ovarian cyst, and maybe also for post-treatment strategy in survivors who receive actually low or moderate gonadotoxic treatment, but want to delay the project of pregnancy. For cryopreservation of ovarian tissue, there is several advantages in adolescents we have discussed, and it's the main option in several centers. The success rate remains uncertain for pubertal patients, but it's higher in young patients, and results are encouraging in adolescents. Thank you very much for your attention.
Thank you, Isabelle, for the fantastic talk.